Good evening to you all. And as every Tuesday, today's is an interesting master class in critical care that Yashoda Hospital conducts this scientific webinar on an every Tuesday. And today is no other day. We have a very important topic today on the topic of polytrauma and management of hemorrhagic shock. So every Tuesday evening, we bring forth very interesting cases and very up-to-date cases in field of critical care by our team of professional experts who are collected from, they are being invited from all over the country. So today we have esteemed teachers today conducting this master class. So let me invite the panel. I'm Dr. Karthik. I'm critical care consultant and HOD in Yashoda Hospital, Somajiguda, who will be moderating today's session. So today's session on polytrauma and management of hemorrhagic shock would be presented by Dr. Manisha Sumant. Dr. Manisha is a second year DNB resident at Citizen Hospital, Hyderabad, and Dr. Sai Venkatesh, who is doing his IDCCM in Citizen Hospital, Hyderabad. We have invited esteemed faculty today, Dr. Rakesh Garg, who is a professor from AIMS in Department of Onco-Anesthesia. Dr. Rakesh is a person who needs no introduction. He's been editor for the IGA and has published many national and international research articles. And we would like to invite you, sir, and thank you for having accepted an invitation today to be a scientific member who would be taking and sharing his expert advice on this very important topic. And we have Dr. Sangeeta. Dr. Sangeeta is a senior consultant in Apollo Hospital, Hyderabad, Hyderabad. And she's been really reading panelist in this field of trauma and management of hemorrhage in polytrauma. So I would like to thank Dr. Sangeeta for having accepted the invitation today. Welcome, Dr. Sangeeta. So with this brief introduction, we will dive into the case. So the case presentation will be done by our students, Dr. Manisha and Dr. Venkatesh. Over to you, Dr. Manisha and Venkatesh.
Yes, sir.
A very good evening to everyone. So today's case presentation is that of a 24-year-old male patient who was involved in a two-wheeler versus car collision at around 9 a.m. near Nallaganda. He was brought to the Citizens ER by Emergency Medical Services around 30 minutes post-injury with an estimated onset blood loss of 500 to 800 ml from the right thigh. Pre-hospital, he had a cervical collar and pressure dressing applied to the right thigh and was given 500 ml of crystalloid solution. So on coming to the primary survey, on arrival, catastrophic hemorrhage was identified from the right midshaft femur. Pressure dressing was already in place. A pelvic fracture was suspected and pelvic binder was applied as an early hemorrhage control method. Airway with cervical spine. Airway is patent and cervical collar was in place. Breathing and ventilation. The patient was initially tachypnic with a respiratory rate of 30 cycles per minute and SpO2 of 88% on NRBM. Clinical examination showed decreased air entry on the right side. It was hyperresonant on percussion and there was tracheal deviation to the left, raising a suspicion of right pneumothorax, which was confirmed by ultrasound, and an intercostal drain was inserted, after which SpO2 improved to 98%.
Can you change the slide, please?
Next.
Okay. Yeah, please continue, Dr. Manisha.
Okay. Coming to the circulation part, the patient's heart rate was 132 beats per minute, BP of 70 by 54 mmHg. The peripheries were cool and there was delayed capillary refill time. EFAS showed positive. EFAS was positive in the right upper quadrant with free fluid, approximately 250 ml. And there was pressure dressing on the right thigh and pelvic binder were in place. Next slide. Coming to the disability, the initial GCS of the patient was 14 by 15. Pupils were 2 mm reacting to light. he became progressively drowsy in the ER with a GCS drop from 14 to 9. So he was intubated with rapid sequence induction while maintaining the manual stabilization of the cervical spine. On exposure, the patient was fully exposed. There was a notable deformity on the right midshaft femur, and pelvic binder and external splints for the femur were in place. Next slide. Coming to the resuscitation part, two 16-gauge IV cannulas were secured in the right and right and left upper limbs of the patient. 1 liter of warm balance solution was rapidly infused. There was a transient response for this crystalloid solution, and hence 1 unit of O negative blood was started. He received Tranexamic acid 1 gram bolus. Police catheterization was done after ruling out the urethral injury, and patient was shifted to ICU with CT polytrauma and contrast en route.
Yeah, so we'll just stop here, and can you summarize what were your findings? And we'll take some questions from our examiner, and then we'll proceed to the next slide.
Okay, here we have a 24-year-old male patient who met with a road traffic accident, two-wheeler versus car. And on site, it was seen that the patient had an open fracture of the right femur, and around 500 to 800 ml of blood loss was there, as informed by the emergency medical team. And as soon as he came to the ICU, the patient had a GCS of 40, but then his saturation was low. His saturation was low, and he had tachycardia and hypotension, tachycardia of 130 and BP of around 70/50. On XABCD examination, there was a open fracture of the right femur where pressure dressing was applied to look for the catastrophic bleeding, and the suspected pelvic fracture was also there, for which there was a pelvic binder that was applied. Coming to the airway was patent initially.
Just a moment, Dr. Manisha, to interrupt you. In your ABCD survey, you mentioned that the airway was patent. So, as per ATLS, can you tell me how do you quickly assess that? What is the ABCD of the patient? There's a very quick 10 seconds way to assess. Yeah.
Dr. Rakesh, sir, your mic is on mute, sir. Yeah.
So according to the ATLS guidelines, we check for XABCDE. So airway will check whether the airway is patent. Will try to communicate with the patient and look for his saturation. Coming to the breathing, we'll check whether the bilateral air entry is equal, his saturations, and whether he's tachypneic.
Yeah. So quick way to assess is you ask the patient, what is your name and what happened? He is able to tell his full name, complete a full sentence, and able to narrate the incident. It means airway is patent, breathing is fine, he is able to complete a sentence normally, and brain also looks okay for the time being now. Agree with it? So it's a quick 10-second way to know that airway, breathing, circulation, and visibility, that the brain status is okay for the time being. So that's a quick way. Okay, next.
Summarizing with the breathing, there was initially it was noted that the patient was tachypneic and hypoxic. On examination, clinically, it looked like he had a right pneumothorax, which was confirmed by ultrasound, and ICD was placed. Coming to the circulation part, the patient was tachycardic and hypotensive. And for the which 1 liter of crystalloid was started. And disability, though initially immediately after arrival, the patient had a GCS of 14. Later, he became.
Yeah. Just a moment. For the circulation part, patient has hypertension. So what do you think is the cause of this hypotension at this point of time? Commonest causes in trauma and hemorrhage. So can you tell us the classification of hemorrhagic shock? What is the causes?
There are basically grade 1 to hemorrhagic shock is classified as grade 1 to 4. Grade 1 is somewhere between 10 to 15% of blood loss. Grade 2, that is mild, is 15 to 30%. Grade 3 is 30 to 40%, and grade 4 is more than 40%. And depending upon this, there are also the clinical signs where the heart rate is less than 100 in grade 1. 100 to 120 in grade 2, 120 to 130 in grade 3, more than 130 in grade 4. And pulse pressure starts to decrease from grade 2 hemorrhagic shock onwards. In grade 1, it's normal. And consciousness also, the patient is slightly anxious in grade 1 and 2. From grade 3 onwards, he starts to becoming a bit drowsy, and by grade 4, he is very much lethargic. So at the same time, we will also look for the respiration as well. In grade 1 and 2, there is no much change in the respiration, whereas from grade 3 onwards, he starts to become slightly tachypneic.
Sir, Dr. Rakesh, sir, anything
Yeah. So,
you would like to
ma'am,
ask?
any more questions from your side, ma'am? Yeah.
Yeah, so just to
So,
No, Dr. Rakesh, your voice, we are not able to hear your voice.
Just hold on, sir. Is it better, sir, now?
Not yet, sir. I'm not able to hear your voice still.
Please check
Is
the
it better
internet.
now, sir?
No, sir. Please check the internet once.
Yeah, Dr. Sangeeta, you are asking some question regarding the
So
resuscitation.
important point from this classification is we need to identify the stages of this large volume blood loss, that is 3 and 4 especially, where you would want to undertake some emergency steps. Like 3 and 4 are the ones where sometimes you may have to activate the
Dr.
massive
Sangeeta, your
transfusion
voice is
protocol.
also cracking up. Can you just adjust your voice a bit? Maybe mic is too near, maybe little bit.
Are you audible now, sir?
Yes,
Is
sir.
it
We
better?
are audible. You are audible now. Yes.
Right. So I think by the time ma'am is ready, so
Yeah.
I have a couple of questions for you. So when you say the mechanism of injury, a patient arrives into the emergency department with history of trauma. So based on your patient, can you just think of what possible injuries patient will have, and probably based on mechanism of injury, how will you grade them? Or how will you think that which type of issues this patient can have?
So based on the based on the kind of road traffic accident it was, that is a high velocity collision between a two-wheeler and a four-wheeler. So if in case the patient is not wearing a helmet, he might sustain a head injury, and there can be a long bone fracture as well. So depending upon the injuries, or depending upon the kind of RTA, we can divide the patients into patients who could have sustained a major trauma. Like if it was an ejection injury, there's more possibility of a cervical spine fracture. Or
So we have discussed, you mentioned two things. One, if it is two-wheeler versus four-wheeler, right?
Yeah.
Then you said on two-wheeler, it is with helmet or without helmet?
Yes, sir.
Whether he was driving or pillion.
Yes.
So this will decide the mechanism, right? Now, if it is four-wheeler, you have to say whether he was the front driver seat, or the back seat, number one. Number two, was he wearing a seat belt? Number three, was the driver or the pillion or the co-passenger was ejected, and how much distance? Now, these are important parameters to grade or suspect injury, because in trauma patient, you should have high index of suspicion for any trauma. So this needs to be there when you ask history when the patient arrives, or if the patient, somebody who is who has bystander who has brought the patient. So this history should be there, because you mentioned in your history 24-year male, high velocity road traffic accident, two-wheeler versus car.
Yes, sir.
And also, when you say this, if any person has died in this accident, even though this person was survived and reached there, but any death in that accident is again indicative of a high risk injuries. So this mechanism is very, very important when you should elucidate. Fine?
Yes, sir.
So based on this, you can always reframe and you can tell the extra things.
Okay.
Madam has asked nicely questions about you, but when you came to C aspect, circulation with hemorrhage control. So now, what type of responder it was? You gave around 1 liter of warm crystalloid.
Yes, sir.
So what type of responder he was?
Transient responder.
He was a transient responder, sir.
Right. So if there is a transient responder, and then you said the patient from the ED was shifted to ICU via in-house radiology.
Yes, sir.
Now, can you just comment upon this? If a patient is a transient responder,
Yeah.
and patient EFAST is positive,
Mm.
indicating hemorrhagic shock,
Yes.
do you think he needs imaging? You said CECT. Or it should be monitored and shifted to OR for hemorrhage control, because you mentioned circulation with hemorrhage control.
Yeah.
So what you justify that why a patient of bleeding with unstable hemodynamics, with transient responder, with grievous injuries, right? As per the mechanism of injury, why he was shifted for CECT with EFAST positive.
So though he was a transient responder, we had started him on a O negative blood group, and we went ahead with the imaging because there was a mild collection in the EFAST, but then we did not know the extent of injury. We wanted to see if there is any active contrast leak. We wanted to know what kind of injury we are dealing with before we shifted him to the OT. So
if I put it this way, that the CCT, the CT room is the graveyard of trauma patient. I repeat, CCT is the graveyard of the trauma patient. You justify why you did for your patient, why he was shifted to a graveyard. You justify what I said. Because he was hemodynamically unstable, grievous injury, EFAST positive. So you were aware of what is happening to the patient,
yes.
right?
Mm.
Patient clinically can have fracture. He was having probably an open brook fracture because there was a pelvic instability, pelvic binder were on,
Yes,
but
sir.
EFAST was positive in right upper quadrant. When you say right upper quadrant, just justify that which patient should show CCT, which patient should go for OR. Just I want you to explore. So I'm not saying something is right or wrong, but I just want to think of that which should be the right path from the exam point of view.
If the patient is a rapid responder,
If the patient was if we were not able to maintain the hemodynamics despite of PRBC, then maybe we could have directly went ahead with the exploration, sir. But as I was telling before, because we were not sure, though there was a collection, we were not sure that's from the source for which, because of which there was a collection in the abdomen. And we also wanted to look for any other vessel injury or active leak. That's the reason why. So in order to achieve hemostasis, we also need to know where exactly to look at rather than shifting to the OT and then trying to explore there. That's what was the thought process.
Okay. So now you have to look for both the aspect. So when we say at many times now, because of the presence of intervention radiology, so your answer should be clear in exam.
Yeah.
If you suspect a liver laceration, depending, that's why my first question was the mechanism of injury. If you see a seat belt lacerations on a driver's seat and it is on the right upper quadrant, so probably it will be a liver laceration. And liver laceration would require maybe some amount of radiological interventions in maybe sometimes the embolism, the embolization. So when you speak in exam, your point of your clarification should be clear that he was shifted for this purpose, whether this patient is amenable to intervention radiology for embolization for control of bleeding. This is one, right?
Okay.
Secondly, it should be related to your mechanism of injury. So you should relate both the aspects.
Okay.
Right? So exam, you should be clear that what for you are shifting to the radiology. It is just not for looking for the signs of injury, right? It is with high neck suspicion, and you should also look for that if something comes, you should be ready with intervention embolization if there is a big vessels or bleeder, right? Sometimes when there is a pelvic fracture, there could be bleeder vessels somewhere. So again, nowadays, they don't go for operative interventions. They go for interventional radiology interventions. So you should answer this way. Because otherwise the older term, when the interventions was not so strong, it was considered as graveyard. So that's why nowadays with intervention radiology, you should clear. Okay. Next, you mentioned about that patient was intubated for airway protection and RSI was done.
Yes.
Now, can you just expand on that? How was the airway management done in this patient?
So for this patient, though his initial GCS was 14, rapidly he deteriorated with a falling GCS. So at that point, we did a manual inline stabilization of the cervical spine, and rapid sequence induction was done. So bolus dose, we kept a vasopressor ready because this could be a physiologically difficult airway. So the one person was standing onto the right side of the patient, and he did a manual inline stabilization of the neck. The person who was intubating, who was a senior there, he was standing at the head end. We had asked the sister to give a 100 mg bolus dose of etomidate, followed by a 100 mg bolus dose of rocuronium. And before we gave the paralytic agent, we asked our colleague to apply a cricoid pressure, and then under direct laryngoscopic vision, we had intubated the patient.
So which drug did you use for RSI and how much?
Etomidate, sir. Etomidate,
Etomidate.
Yeah.
And etomidate along with?
Rocuronium.
Rocuronium, good, right. So any concerns about etomidate for this group of patients, and what are the recent guidelines which mentions the drug of choice, induction drug of choice for a trauma patients with the hemorrhagic shock? A couple of good studies and reviews has come up in last 3-4 years, which talks about some other drug also.
Ketamine, sir.
Yeah, good. Ketamine is the other drug which is coming into this, because when we say etomidate, now these patients are on catecholamine surge, which maintains the sympathetic tone of these patients, maintaining the hemodynamics. When we use etomidate, it leads to the suppression, adrenal suppression, and that catecholamine surge sometimes can go down, and these patients can go sometimes in vasoplasic format, and the BP can fall. So this is one side effect, though etomidate remains a drug of choice for hemodynamically unstable patients. So that's why the recent studies have started using that if somebody has an acute trauma, the ketamine can also be used for these patients, but with a caution that if you see your patient, his GCS has fallen from 14 to 9.
Head
right?
injury will be a problem.
There may be a head injury, though they were concerned that it can increase the intracranial pressure. So that's why you have to have a balanced approach. So when you speak in exam, a particular drug, you need to consider its pro and con. You rightly mentioned about physiological difficult airway for this patient. The rest of the things you did very well. So this is an absolutely right option. Simultaneously, you should also be very clear when you speak in exam, the trauma patients can have a airway bleeding.
Yes.
So when you try to manage this patient along with cervical spine, be clear that sometimes the airway bleed can aspirate. So herein you also should always speak in exam that a wide bore cannula, not catheter, wide bore cannula should be kept ready, suction cannula, so that in case there is bleeding or clot, it can be suctioned off. Right? So this is another important point when you manage this airway. Third, I mentioned about the increase in intracranial pressure. So these are a couple of things from my side till now. Over to you, madam. Sangeeta, ma'am.
Yes, sir. One question regarding the rapid sequence intubation. Regarding the cricoid pressure that you mentioned, is it a must?
No, it's not. It's not must, ma'am. Sometimes it's said that because of the cricoid pressure, it might be difficult to visualize the vocal cords. But then again, there was this risk of aspiration also, because we, from the history that in the further slides that we'll get, he had a meal just 2 hours before. So that was the reason why we went ahead and applied cricoid pressure, because we.
Yeah. So yeah, it may, but studies have not shown that cricoid pressure definitely helps to prevent aspiration-related mortality, because imaging studies most of the times have shown that the esophagus may not be exactly behind the airways, may be to the left, and therefore it may not help to prevent aspiration. Second, because pressure may interfere with your visualization and intubation. So if that is happening, you have to release it.
Okay.
So just a small thing. This airway management was done prior to the CT scan, or it was done once the patient was shifted to ICU?
Prior to the CT scan, sir.
Okay. So when you have put the patient on mechanical ventilation, and this patient has rib fractures,
Yes, sir.
and you have given a relaxant to these patients.
Yeah.
So when we have a history of chest trauma, do you think we should give relaxant and mechanically ventilate these patients? Because patient already have a suspicion of chest injury, which was later on subsequently confirmed in CT scan.
Yes,
So if somebody has even a small pneumothorax, if you ventilate it, it will become tension pneumothorax. So what was the reason for you to put in on mechanical ventilation before clinical evaluation for chest trauma?
We had already put him on a ICD, sir, because it was confirmed on the ultrasound that he had a right pneumothorax. So he was already on the ICD. So even when we are ventilating, we need to ventilate it with low PEEP, sir.
Right. So this is what I'm asking. Chest tube was put before the airway management, or it was put after the airway management?
Sir,
In slides, you said in ICU and patient was intubated earlier. That's why I'm just clarifying.
No, airway was initially patent, sir. After putting the ICD, after some half an hour time, he started to have a decrease in sensorium. That is when we went ahead. After putting the ICD, we put him on ventilator and then did a CT
Right.
and then shifted
Fine.
to ICU.
Fine. Then fine. So this is an important message that in case of any suspicion of chest injury, even if a patient requires for airway securing, maybe because of GCS less than 8, or patient is having risk of airway bleeding, in those situations, even if it is intubation required, patient should not be put on mechanical ventilator, right? He should be oxygen supplemented in case if there is suspicion of chest injury. Once it is ruled out, then you can put on mechanical ventilation. And if there is a chance, then you should need to put ICD, and then they can be put on mechanical ventilator. So this is an important point, managing the trauma of the chest in case of any multi-trauma victim. Thank you. Over to Madam.
You have given Tranexamic acid to the patient. So what is the evidence and how do you give it?
So the usefulness of tranexamic acid in trauma was initially demonstrated in CRASH 2 trial, ma'am, where they have given 1 gram of tranexamic acid within 3 hours of trauma and followed by 1 gram over 8 hours infusion. There was a mortality benefit. Subsequently, in CRASH 3, they have also tested the same for traumatic brain injury, which also had better outcomes.
Okay.
So shall we proceed with the case, Manisha, regarding the resuscitation and the imaging findings?
Yes, sir. So before shifting to the ICU, the patient had undergone a CT polytrauma with contrast, which revealed a right frontal hemorrhagic contusion. Cervical and spinal and lumbar spine were normal. Patient had sustained a rib fractures on the right side from 5th rib to 11th rib. There was a right pneumothorax and ICD was in situ. There was also a small lung contusion that was noted. And the CT scan also revealed that there is a grade 2 liver laceration, but then there was no active contrast extravasation. Pelvic fracture, which was initially suspected, was also confirmed, and there was a right femur fracture as well. Play the video. So this is the CT scan and the CT brain images, which is showing the pneumothorax and the contusion. There is a small free fluid collection around the liver, sir. Next. This is the 3D reconstruction of the pelvis, which is showing an open book pelvic fracture and the right femur fracture, displaced fracture. Next. So on arrival to ICU, the patient was sedated and paralyzed upon arriving to the ICU, and pupils were bilateral 2 mm and reacting to light. His heart rate was 125 beats per minute, BP of 80 by 50 mm. Previous slide. BP of
Can we go back to the previous slide, please?
the one before this.
No, the back. Yeah, back.
Yeah, this one. So BP of 80 by 55 mmHg with ongoing PRBC and noradrenaline at 5 ml per hour. SpO2 was 99% on mechanical ventilation with 50% FiO2. ABG revealed pH of 7.04, lactates of 9, bicarb of 8, and a base deficit of 12. So injection tranexamic acid infusion was continued in the ICU, and massive transfusion protocol was initiated with 1:1:1 ratio of PRBC platelets and FFP. Next slide. So coming to the secondary survey confirmed no additional injuries. Head and face were normal. Cervical collar was in place. Abdomen was soft. As the patient was sedated and paralyzed, his tenderness could not be assessed. And serial EFAST was done to monitor for evolving collections. Pelvic binder was in place with.
Dr. Manisha, can we just stop before we shift to the secondary survey?
Yeah, sir.
If you go to the previous slide, can you just, as a student, can you just explore on two aspects, madam? One is regarding the hemodynamics. Patient was still having lower blood pressure because lactates were increasing. It was 9 now, right?
Yes.
Though I think previous ABGs, I'm not sure what it was, but it appears that it was an ongoing increasing trend. This is one.
Yes.
And then you said massive transfusion protocol was initiated. So when we say massive transfusion protocol, does it mean that patient was having ongoing requirement of blood? If yes,
Yes.
when do you say that at this point of juncture, patient requires some intervention versus continuation of blood products?
As right from the history that was taken in the ER to the ICU, depending upon the nature of injuries, the risk stratification scores that we use to suspect that a patient might require for a massive transfusion protocol, they were the ABC score and all, but there were more than 2, sir. So the probability of requirement of MTP was suspected, and the protocol was initiated in the ER, which I forgot to mention. And for intervention purpose, as the CT report and all, they didn't show any active extravasation as such. We had discussed earlier, the damage control radiology or for embolization and all, the patient was not taken up for that. Rather, he was shifted to the ICU, and we continued to give him blood products.
So what do you think at this point of time was the possible reason for patient to remain hemodynamically unstable, requiring continuous supplement of the 1:1:1 protocol? Somebody has asked in the chat also, what do you mean by 1:1:1? So these two questions you can answer.
Despite of receiving 1 unit of PRBC, the patient continued to be hypotensive and tachycardic, sir. So this says that we maybe there's more volume loss as to what was estimated on field on field. So we went ahead with massive transfusion protocol. Massive transfusion protocol means giving blood products like PRBCs and fresh frozen plasma and platelets in equal ratios, so as to address the ongoing bleeding and also to address the coagulopathy or to prevent dilutional coagulation. Coagulopathy.
Right. So what are your suspicions for the ongoing blood loss? Do you think it was a cardiac cause in addition to the hemorrhagic shock, or it was purely an hemorrhagic shock? Just preliminary till this, we know that in secondary survey we'll be having a detailed examination and we'll be able to. So if I ask you differential reasons for patient to be hemodynamically unstable, requiring vasopressors, requiring blood products. So what will be your differentials right now up to this stage?
So one thing is, in our patient, he had an open book fracture of pelvis and he had a open fracture of the femur and grade 2 liver laceration. All these things could be source of hemorrhage. And otherwise, in general, for trauma patients, for a source of hemorrhage can be a cardiac tamponade or a great vessel.
For this patient, we are talking about this patient only.
So for this patient, these three are the main things, sir. The grade 2 liver laceration, open pelvic fracture, and the right femur fracture. So these three things are the main culprits for
Right.
the cause.
Right. Over to you. Yeah, if ma'am wants to ask some question. Dr. Sangeeta, please.
Yeah, can you elaborate more on damage control resuscitation?
Damage control resuscitation.
You've already spoken some.
Damage control resuscitation, it mainly involves, it is mainly to prevent the hypothermia, metabolic acidosis, and the coagulopathy, ma'am. So for that, the massive transfusion protocol was given in the 1:1:1 ratio.
So damage control resuscitation, it mainly addresses to terminate or to address the major causes for a patient's deterioration, whether bleeding or anything. So here, as my colleague was telling, we'll address all the factors like hypothermia, acidosis, and coagulopathy, so that to achieve rapid hemodynamic stability
and to maintain the organ perfusion.
Rather than targeting a definitive management.
Basically, physiological resuscitation, which involves the principles of balanced resuscitation, as you mentioned, using plasma, platelets, and BT in the ratio of 1:1:1. Then we try to minimize use of crystalloid fluid or the use of blood products, right? Because excessive use of crystalloids has been shown to promote or worsen the legal triad of trauma. At the same time, your first step, as Saket mentioned, you will vigorously try to find out the source of hemorrhage and try to control it. And you can't just go on giving blood products. You can't just go on working on your MTB. So next, what we try to do is, if indicated and if there's a source of vigilance is found, there's something called as damage control surgery. So what is damage control surgery? Next question.
It includes the minor procedures that that is done to prevent or to stop the bleeding.
Ongoing bleeding, like the like embolization or just surgical packing, rather than going ahead with a definitive management for the defects.
Before shifting to the IC or OT.
Yes, so it's like side by side with the resuscitation going on in order to achieve rapid hemorrhage control or dose control. So rapid applying a ligature or embolization or achieving the applying slips or cleaning the contamination and closing the wound quickly, doing a procedure of a short duration for about 60 to 90 minutes, and then you shift the patient back to the ICU. After that, you try to bring about physiological corrections, that is, try to correct your legal side and all the physiological derangements on the organism. And later on, after this, after 48 to 72 hours, the patient can go for definitive surgery. Anything more to be added, sir?
I think covered this time. We can move a little to the next man.
Dr. Sangeeta, please check your mic once.
Am I audible?
Yeah, you're audible. Your voice is coming broken. Yeah.
Okay.
Yeah, continue, Dr. Manisha.
So going ahead with the secondary survey confirmed no additional injuries. Head and face were normal. Cervical collar was in place. Right side at ICU was functioning well. Abdomen was soft. Tenderness could not be elicited as the patient was sedated and paralyzed. Serial EFAST was done to monitor for evolving collections in the abdomen. Pelvic binder was in place and there was no external bleeding. there was no blood at the urethral meatus and urine was clear. Coming to the extremities, there was a right femur fracture with splint in place and the distal pulses were palpable. The patient was log rolled and back and spine were examined for wounds and hematoma, which were not there. Neurologically detailed examination was limited by sedation and paralysis, but pupillary and brainstem reflexes were intact. Next slide. Coming to the ample history, there was no significant history, and the last mean was 2 hours back. His injury severity score was 17 and was in class 3 hemorrhagic shock. Next slide. Coming to the initial lab parameters, his hemoglobin was 6 gram per deciliter with platelets of 1.1 lakhs. The PT-INR was 28 by 1.8. APTT was 60 seconds. Fibrinogen was 90. ABG was showing metabolic acidosis with lactates of 9 and base deficit of 12. The liver function tests were normal. And blood group, he was B positive. Next slide, please. So, as fibrinogen was 90 milligram per deciliter, cryoprecipitate transfusion was also initiated to maintain the fibrinogen levels of more than 150. And massive transfusion protocol was continued with the target to achieve SBP of there's a slight mistake. SBP of 100 to 110 mmHg and MAP of more than 75 mmHg, or hemoglobin target of more than 7 milligram per deciliter, platelets of 1 lakh, INR of less than 1.5, and APTT less than 1.5 times the normal. Ionized calcium was monitored and corrected with IV calcium, targeting ionized calcium value of more than 1.1. Normothermia was maintained using warm blankets and fluids with a target temperature of more than 36 degrees centigrade. ABG base deficits and lactates were monitored serially to assess for perfusion and guide resuscitation, aiming for lactates of less than 2 and base deficit of less than -2 and the normal pH. So this is the slide showing the serial ABGs. As we have already mentioned, at baseline, the pH was 7.04 with the bicarb of 8 and lactates of 9 and a base deficit of 12. After 6 hours, we started to notice the pH started to improve with a pH of 7.2 and lactates of 9. By the end of 24 hours, the pH and lactates have almost normalized. With a pH of 7.36 and a lactate of 1.5. Next slide. Okay. We had completed 24 hours. This is on day 2 of ICU. The hemoglobin has improved with improvement in the coagulation parameters, and also the fibrinogen was also 180 milligram per deciliter. Next slide, and the other one after this, please. So patient's hemodynamics improved over a period of next 36 hours and was on minimal NORAD support. He was taken up for pelvic and femur fixation to the OT. By POD3, patient was extubated and discharged out of the ICU on day 4.
Okay. So with regards to resuscitation, what would be your resuscitation targets? Like HB, platelet, INR?
INR should be less than 1.5. Platelet should be more than 50,000, ma'am. And HB should be around 7 to 9 grams per deciliter.
Okay.
HB
count in case of TBI?
More than 1 lakh.
More than 1 lakh. And fibrinogen should be maintained.
Yeah,
fibrinogen should be maintained more than 150 milligram per deciliter.
So what is permissive hypotension?
Permissive hypotension, it is when it is in the balanced resuscitation, ma'am. We have to maintain we should not target the MAP, ma'am. It should be around 50 to 60 mmHg, so that we should maintain the tissue perfusion and we should not increase the MAP.
So we are accepting a physiologically lower
Physiological.
level of blood pressure, so as to avoid dislodgement of any
Clot dislodgement.
clots that could have contributed to controlling hemorrhage. But whereas in TBI, if the patient has sustained any brain injury, we do not go for permissive hypotension, and we target map of 100 to 110. We target a
Systolic blood pressure of
100 to 110.
And map more than 80.
Okay.
Just a small comment. Patient has multiple rib fractures. What was the treatment modality for this? You mentioned that the pelvic fixation was done, femur fixation was done. So what, according to you, is the management of rib fractures while the patient was on ventilation? Or I would ask you direct question, what was the analgesic technique for this patient, because he was having multiple trauma and rib fractures were there. So what was your modality of analgesia for such patients?
So the patient was already on sedation with fentanyl, sir. Along with that, we had also added paracetamol. So this had taken care of the analgesia part.
What do you think, because this patient has poor GCS in one point of time, any concerns with opiate? And my second question is, any concerns or any utility of using other regional blocks which can avoid opiates, though this patient was not having head injury. Probably the low GCS was because of hemodynamics and low perfusion. But suppose this patient was also having had contusion. So in those situations, what is the role of other analgesic techniques wherein you want to avoid the opiates?
Definitely other analgesic techniques like intercostal nerve block could be considered, sir, to relieve the pain. And being off opiates would have allowed better monitoring of GCS. So any deterioration or anything could be picked up early.
So in exam, sometimes this can be asked to you also. So you can put, say, epidural. Nowadays, we put paravertebral blocks. Nowadays, we put facial plane blocks or intercostal also. So you need to know, as for exam, that what are the roles of these various blocks that can be given, and when to give morphine and when not to give morphine to these patients or other opiates in case if they have suspicion of the other injuries. You should be aware of those aspects, right? And also, you also need to think when will be the right time to remove the ICD for this patient. Because you have put an ICD, since patient is, you said extubated and discharged out of ICU on day 4. So probably we should also start thinking of which will be the right time to remove the drains in these patients, because these are potential source of infections.
Yes.
So removing those drains should also be somewhere examiner can ask at what point we should remove the drains. So anything which is less than 100 ml over 24 hours, lung appears to be expanded. It's serous fluid or clear fluid. At those point of time, you can think of removing them, the drains, this chest tube, so that source of infection reduce. And chest tube also causes a lot of pain, and patient will be uncomfortable and will not be doing chest physiotherapy, which will be required for this patient. And hence we should remove as and when possible. Right. Over to you, ma'am.
Initially, during resuscitation, we discussed about MTP. We discussed when to start it. When do you stop MTP?
So when the patient is hemodynamically stable and all the coagulation parameters that we have talked about have normalized, that's the point when we can consider stopping a massive transfusion protocol.
Correct. Provided the hemorrhage control has been achieved, the source of bleeding has been managed, you are seeing physiological parameters improving, patient is stabilizing, and maybe a bit earlier, like instead of balanced resuscitation, we can move on to goal-directed resuscitation. Because now that your patient is on the improving stabilizing pathway, like somebody has mentioned in the chat, role of TEG or ROTEM. So if you have it, you can be using it, patient is stabilizing. So the individual coagulation parameters or the hemoglobin, you can correct it as and when whatever abnormality is there. So you are now trying to cut down unnecessary blood product usage.
Somebody has asked in the group about the DVT prophylaxis.
Yes.
These patients may be bedridden for a long time because the patient has pelvic fracture. Patient also has femur fracture. So probably they will be on bed for some time, though we start them on physiotherapy. So what do you think the role of DVT prophylaxis is there in such patients? On one side, we were struggling about the hemorrhagic shock and oozing and bleeding somewhere from liver laceration and other aspects. And on the other hand, these patients also remain at high risk of DVTs and subsequent embolism. So, what is your take on various
Initially,
type of thromboprophylaxis for this patient?
initially we start him on pneumatic compression
Compression
stock.
devices as soon immediately, sir, because it
It's more-
won't have any effect on the bleeding and all. So once the operative correction is done, like the pelvic fracture and the femur were addressed, and once we are also confident that there's no more increase in the abdominal abdominal free fluid collection, after discussing it with the surgeon, we can immediately start with chemical DVT prophylaxis as well, like heparin. Like Lexian.
Right. So I think when you speak in exam or for otherwise clinical, so you have to individualize the patient. So now individualization will vary with each patient depending upon at what situation it is. If you think that the drains, the ports are not having any high colored output from them, there is no trend in the decreasing hemoglobin for these patients, and the hematoma and other skin changes are not there. Till then, you should always think of mechanical devices for DVT prophylaxis. You said pneumatic one. Similarly, in this patient, movement may be an issue because she was having pelvic fracture. So we cannot do active mobilization. But otherwise, these patients should be actively mobilized by physiotherapy so that the chances of DVT are reduced. So these are the, if you remember, the triad, the virtuous triad for these type of increased incidence. So this patient has trauma. There is some vascular injuries, multiple transfusion protocol you have given. So they can have all those issues. So that's why you have to balance it. And depending upon situation, so there's nothing called on day one, you will start them on, say, Clixane or Deltaparin or other products. So depending upon situations, you will take a decision to start on. Also, you look for, there are certain scoring systems for high risk of DVT. So you have to use those scoring systems to stratify your patients and start them on DVT prophylaxis accordingly, depending upon the risk factor and balancing bleeding versus DVT in these patients. Over to you, ma'am.
Yeah. We saw that our patient had a femur fracture. So he had a musculoskeletal injury with hematoma formation. So what more complications would you look for in this kind of injury pattern?
As we can expect, rhabdomyolysis, ma'am, or any compartment syndromes. But in our patient, as in the secondary survey, we have seen the distal pulse is palpable, so which was seen throughout the ICU admission. So we didn't suspect this compartment syndrome, ma'am. And even we sent CPK levels, which came to be normal.
There could also be fat embolism.
Embolism. But here in our patient, it is mid-shaft fracture.
Yeah, and one point I would like to bring is the liver injury, right? So this patient had hemoperitoneum and there was grade 2 liver injury also. So when did you start low molecular weight in this patient of yours?
Day 4, sir.
Day 4.
Yeah, while he was getting shifted out of the ICU.
Okay. Right. So, we have like discussed about lung contusion and lung protective ventilation strategies that we need to consider, and the low molecular weight heparin, and it's when we time it to start. How about like tranexamic acid? Can you throw some light on that aspect, like tranexamic acid and its role? What did the CRASH 2 and CRASH 3 trials say, and what were the conclusions of those trials?
CRASH 2 trial was mainly looked into use of tranexamic acid in trauma patients. So what they have observed was when tranexamic acid was given 1 gram IV over 10 minutes as a bolus dose within 3 hours of surgery and continued over 8 hours, 1 gram, 8 hours infusion. They noticed that the patient, the clinical outcome was better. This was of CRASH 2. CRASH 3, they looked for tranexamic acid in traumatic brain injury, which also had similar results. There was a better patient outcome.
Yeah, so crash kit didn't have any survival benefit, but the neurological outcomes were better after 6 months of admission, right? So, okay. There is a question here from one of the delegates here who had asked about role of factor 7 in the traumatic bleed management. Recombinant factor 7 role.
So if the patient continues to have a torrential bleed despite all the maximal conventional management,
medical and surgical,
surgical management, that is the time when we consider giving a recombinant factor 7 infusion. The goal is to just maintain supraphysiological levels of factor 7. That's all. There's no target as such.
So some basic prerequisites you require when we use factor 7. Basically, it is like a correction of your, coagulation parameters where you are deficient in platelets, FFPs, and then its role is also in blunt injury abdomen. If you read the ATLS guidelines, it's more in the blunt injury abdomen where its role is there. And you should not have confounding factors, like your acidosis or
hypothermia.
Yeah, so these things should not be there. Then only you should think about using recombinant factor 7, right? Okay. Any more questions, Dr. Sangeeta?
Last question on similar lines. When would you consider using PCC?
If patient is on prior history of usage of anticoagulants, ma'am, then we will use the PCC.
Yeah, Dr. Rakesh, would you ask any questions? Dr. Rakesh, are you there? Okay. So what about the one of the delegate is asking about the rib fractures. What would you do if you have a multiple rib fractures with flail chest and you are, deciding to wean ventilation? How would you take care of it? Do you require any surgical intervention or not?
Yes.
If it's a flail chest, then we'll go ahead with the surgical intervention, sir. Otherwise, if it's just rib fractures, then it can be managed conservatively.
Okay. What problems do you anticipate with flail chest in terms of oxygenation?
There'll be hypoxia.
Yeah, before that's my question was before intubation. Like, what would you see? What would your problems with the flail chest be? Ventilation perfusion mismatch will be there, right? So when you are before intubation, when the patient presents with ER with a flail chest, how do you define a flail chest?
Fracture at the 2 or more consecutive ribs, sir. It in more than 2 places, sir, and it moves unequally with the respiration.
Right.
Paradoxical movement with respiration.
Right. And how would you take care of this problem? One is you have already mentioned about your analgesia techniques, that is your nerve block, intercostal nerve block, and thoracic epidural. Yes, these are some of the techniques that you have. And if you develop a contusion, when would you develop a contusion, and what would be your ventilation strategies, and what would be your non-ventilation strategies in managing a contusion lung? How would you ventilate a patient?
What would be your ventilatory strategy? Lung protective ventilation.
Yeah, what would be your ventilator settings? Yes, how would you set your tidal volume? How would you set your PEEP?
Low tidal
Tidal.
volume, sir. PEEP in this, we cannot, if we're talking about our patient, then we cannot go on to high PEEP because he also has a pneumothorax. So,
And HPE ratio.
So what problem would you face if you have higher PEEP in this patient?
Barotrauma.
Barotrauma has already been done.
More in
You have ICD there in place.
the
expansion of pneumothorax within the ICD.
non-disease.
No, you would have chance of, having a fistula, right? So when you are ventilating a lung
Bronchopulmonary
higher PEEP, you wouldn't give time for the lung to heal, right? So there would be bubbling through that ICD that you will be seeing. So PEEP is only to recruit your lung, and non-ventilator management would involve fluid balance. That's very important. When you are, managing a patient of lung contusion, you would like to maintain slightly fluid balance on the negative side, not harming your blood pressures or acute kidney injury if this was not there in our patient. But you would like to maintain a fluid balance, a slightly negative cumulative fluid balance in order to improve your lung, right? Right. So there's one more question. If the patient had severe metabolic acidosis in this patient and no urine output for 5 to 6 hours and you're seeing rise in creatinine, what would be your modality of RRT?
We would go ahead with a continuous renal replacement therapy, sir, because there's an issue with the hemodynamics as well.
Yes.
Requiring a massive transfusion and also we would go ahead with the continuous renal replacement therapy.
Yeah, so this question was basically upon hemodynamic stability. It's based on your hemodynamic stability and the reversibility factor. If we are doing for lactic acidosis, then it wouldn't be of much help. If it would have been an acute kidney injury with acidosis, then yes, there would have been a role for doing renal replacement therapy here. And yeah, any more questions, Dr. Sangeeta?
No questions, sir. I think we've
No
covered
question.
it extensively.
Right. So we have touched upon different topics of polytrauma and hemorrhagic shock. So we have seen about, the assessment of your injuries. We have seen about the management of shock and the ways we secure the airway, and how do we go about managing the injuries of the spine especially, and then the management of flail chest, and about resuscitation parameters like your damage control resuscitation, hypotensive resuscitation, and we've even seen the role of massive transfusion protocol, and we have even addressed about the operative and perioperative complications that will arise, and when we would anticipate them, and how do we overcome them, and when do we restart our DVT prophylaxis, right? So this very much covers most of the topic and its related questions that you would encounter if you are given with this case in your exam. And very much we have covered most of the topics pertaining to this lecture. So, Dr. Rakesh, do you have any closing remarks or any questions to ask?
Right. So, Annie, I think most of the things are covered. So this is just for the students when they appear for the exam. Sometime examiner would be asking for recent updates, though we have discussed the management point, which is single-sided. But sometimes in trauma management, there are certain things which are coming updates in recent times. One example I showed you about the recent updates of the ketamine versus etomidate versus combination. But from exam point of view, you should also be aware of recent systematic meta-analysis and recent RCTs, which has been published last 3-4 years. And you should be able to provide pro and con for using these type of differences and updates that are available. Somebody has asked about the epidural versus IV infusion. So depends upon for what reasons are you using it. Epidural infusion of local anesthetic agents sometimes cause hemodynamic instability, and hence you should be cautious about it. IV opiates can be issues with CNS examination, so you should be cautious about it. So when we say for exam point of view, try to have balance in the exam of pro and con. Say, for example, if examiner asks you which is the technique for management of pain in this patient, you should be clear that if I use paravertebral block, these are plus, these are minus. If I use intravenous analgesia, fentanyl based, these are the advantage, these are the disadvantage for my patient. So if you can just pro and con, the examiners will feel that you have good background knowledge and you are tailor-making your information and knowledge for this individual patient management. So this will be a good viewpoint when you speak in exam. So this is a little small tips from my side to the coming exams, and best wishes for your forthcoming exams.
Thank you, sir.
Thank you, sir. And we had one question regarding the TASH score. Do you know about the TASH score? What does it stand, and what is the benefit of calculating TASH score?
TASH, it is trauma-associated severe hemorrhage score, sir. If it is more than 16, then it is an indication for the massive transfusion.
Yes. You know any other score which can predict the need for massive transfusion?
This ABC score, sir. That is assessment of blood component.
And
Yeah. Apart from ATL scoring, these are the scores. Other scores, if asked for an exam, you should be knowing.
And one other shock index.
shock index, RABT score.
Yeah, there are many scores, but you know these are some of the scores that you should know apart from the ATL scoring. Yeah. And I think we have covered much of the topic today, and I mean, it's been an exhaustive discussion, and it has been a very interesting one. We have touched upon the very important topics pertaining to polytrauma and hemorrhagic shock. And I would like to thank Dr. Manisha and Dr. Sai for having made this very, very interesting and very, very detailed discussion and case presentation on this polytrauma and hemorrhagic shock. And I would also thank Dr. Rakesh Garg, sir, for having taken out his valuable time and having spent with students. I'm sure all the students will appreciate your efforts, sir, and will be beneficial for them when they're appearing for an exam. And I will even take this opportunity to thank Dr. Sangeeta, who has taken out time and have given her very valuable inputs about management of polytrauma and shock. And thank you all, the delegates also, for having participated in today's discussion. And Yashoda Hospital believes in imparting education and taking up very relevant topics pertaining to critical care. And we had a very good discussion today. And we would like to say goodbye to you all. And thank you all for joining for today's webinar. Thank you.
Thank you
you,
for
sir.
the opportunity.
Thank you, everyone.